Hello and welcome to today's session. In today's session, we will be discussing about CT assessment of resectability of pancreas adenocarcinomas. This is the quiz which we had sent on some of our social media platforms. I have provided three images which show three different pancreas cancers. And the question was that which of these is a resectable tumor? So we have three different case examples here to go through, which we will get to in our discussion. But you can start typing in the chat section. Make sure that you use the YouTube live chat feature on your YouTube. If it is not turned on, go there and you can start it so that you can participate in the Q&A session of this quiz. So why did we choose today's topic of CT assessment of pancreas adenocarcinoma resectability on today's Saturday live session is because this is one topic which I find is a very valuable topic when you are providing patient care. And if you're assessing patients with pancreas adenocarcinomas, there is a lot of literature out there, but the most important one, which you will find really useful on your day-to-day practice, is this paper from Radiology. It gives you a consensus statement of Society of Abdominal Radiology and American Pancreatic Association and what they feel about developing certain key features of how to decide which pancreatic cancer is resectable and which is not. Let's jump on to learning objectives of today's discussion. Even if you don't remember a whole lot of things which we'll discuss today, there are certain things which you definitely need to keep in your mind. So the way I have designed this talk is to make sure that you retain those things when you leave today's session. Number one, the tumor is resectable if there is no tumor at the celiac axis, SMA, hepatic artery, aorta, IVC, SMV, and portal vein. So when you're doing this CT, if you don't see any tumor at these locations, and remember, we are talking about these assessments when the patient has no other metastatic disease, right? So remember that even a single focus of metastases anywhere is going to render this patient unfit for a surgery. So in the absence of METs, if there is no disease at these vessels, the disease could safely be called as resectable. Then we have to understand what is the difference between abutment and encasement, and these are not the same. The next objective is the disease is unresectable or locally advanced if there is any disease at the abdominal aorta, if there is any celiac axis abutment, and if there is more than 180-degree of superior mesenteric artery encasement. The last but not the least, surgical planning is of utmost importance even in resectable or borderline resectable tumor, because the local specialty of performing different vascular anastomosis can vary from site to site. So make sure that you review these cases or your surgeons review these cases with you to decide if the patient can actually be undergoing a surgery. So these were the learning objectives. So now, looking at these images, you definitely start to notice that some of these areas don't look nice. Like those are in keeping with your pancreas carcinomas. This was our quiz image. So we will dissect one by one. If you look at the image on the extreme left, it's an axial arterial phase CT of pancreas. You definitely see this hypodense mass in the head of pancreas, but you do see that the soft tissue is surrounding the common hepatic as well as the proximal portion of the splenic artery, and there is disease at the origin of the SMA, and there is disease at the aorta as well. So if we just apply the things which we talked about in the first slide, this is an unresectable tumor. Then if you go to far extreme right of this film, there is a coronal maximum intensity projection image on arterial phase, which shows you that this is the common hepatic artery. This is the stent which is put in the CBD, which itself tells you that the patient has obstructive jaundice, or that is how the patient presented. And then you start to see the first branch coming off of this common hepatic artery, which is nothing but your gastroduodenal artery. So in this case, the GDA is completely narrowed by the tumor mass. So up front, it will be very hard to say if this is completely resectable or not. So you have to dissect this case further to make sure that you rule out all the red flags which will prevent this patient from getting surgery. Now, why is it so important to talk about this disease? Pancreas adenocarcinoma is a devastating disease with a very poor 5-year survival rates, which can go all the way down up to 37%. Complete surgical resection is unfortunately the only chance of cure, but many patients present with locally advanced or advanced disease, which renders them surgically not amenable for treatment. CT by default has shown a very high kappa value when it comes to correlation between the imaging findings like this and the pathologic characteristics of the tumor. Plus, CT is very widely available for use, and there are many studies which talk about comparison of CT and MR when it comes to assessing local extent of pancreatic tumors, and that's why it is really important to discuss about CT in performing preoperative assessment. Despite of all of these things, the assessment can be fairly challenging because a large portion of tumors can have a macroscopically undetectable tumor around the blood vessels in the upper abdomen, which is nothing but lymphovascular invasion and perineural invasion, and that renders those patients as quite high for local recurrence or distant metastases even after a surgical intervention. And remember, the surgery itself comes at a cost. It's most of the times if the tumor is in the head of the pancreas, it's going to be Whipple procedure. And the surgery itself is quite debilitating for the patients. And sometimes the patients could succumb just to the surgery and not the tumor itself. So remember to assess all of these things. When you're starting to do these CT scans, remember that you have your protocols really critically assessed, because you don't want to be doing a wrong examination technique and saying that I don't see the tumor. For example, this is a coronal portal venous phase CT. You definitely see that the gallbladder is distended here. And then you also see that the pancreatic duct shows abrupt cutoff of the dilated duct. So there has to be something going on here. The question is that you don't obviously see it because it is so iso dense to the pancreatic parenchyma on this portal venous phase. But you do definitely see that this right lateral margin of the superior mesenteric vein is in close proximity to whatever is there in that region. Now look at the difference here. The moment you start doing pancreatic parenchymal phase on top of your portal venous phase, you start to appreciate the difference. This is the same patient, scan performed at the same time. This is a coronal CT examination obtained in pancreatic parenchymal phase, and now you start to see the tumor because now the tumor does not enhance as brilliantly or it's not as dense as the residual or normal pancreatic parenchyma, and you can distinctly see this mass in the head of the pancreas. So what are the technical parameters of these scans? Remember that you have to obtain one pancreatic parenchymal phase. It's usually around 40 to 50 seconds. You can do bolus tracking to time it adequately. The goal is that you should have nice enhancement of the pancreas so that you can differentiate pancreatic tumors from the pancreas in this phase. So once you obtain that phase, the second phase to obtain is your portal venous phase. And in portal venous phase, it should not be greater than 70 seconds after injection of contrast. What is the volume? It's usually around 100 to 150 milliliters of high density non-ionic intravenous contrast, and it should be injected anywhere between 3 to 5 milliliters per second. That's we usually inject at 4 cc or ml per second, but we also follow that with 20 cc of normal saline flush. That's just our acquisition technique. Now the images have to be acquired in helical mode, and it should be 0.5 to 1 millimeter thickness with similar slice gap, but you can reconstruct them as per your institutional protocols. The coronal and sagittal reconstruction could be anywhere between 2 to 3 millimeters thickness. But that image is just to show you what is the importance of doing pancreatic parenchymal phase in detecting these tumors. Unfortunately, it's not as easy as this case looks like. Sometimes you get a cancer which is like this. So even though this is a portal venous phase, unfortunately, this was the only plane in which I could reconstruct it properly. All you will see is just dilatation of the CBD and dilatation of the pancreatic duct, something which you call it as double duct sign. And then you don't see a mass no matter how hard you try. So when this happens, that you see this dilated ducts and everything, and you don't see a mass in the head of the pancreas, always make sure that you also assess the sweep of the duodenum to exclude a typical periampullary mass. And then once that is done, you can assign this particular lesion as either there could be a cancer at the ampulla or an isodense tumor in the head of the pancreas or a CBD cholangiocarcinoma. All of those could be differentials in that case. The most important thing to remember is that this patient, or for that matter, any patient who is presenting with a mass in the head of the pancreas, needs to undergo ERCP, stent placement, and US guided biopsies of that area to prove the diagnosis. And the most important thing as a radiologist we have to do in this case is to assess if there is any disease which will render this patient unfit for a surgery. because even if you don't see the macroscopic tumor on imaging, you can definitely exclude tumor extension along major vessels in the upper abdomen or metastatic foci. And that should be your goal in this particular case. So let's talk about some anatomic considerations. So I borrowed this image from this article, which I showed you earlier. This is again the DOI of the same article. It is really important to divide pancreas into head uncinate process and body as well as tail. And remember to use your SMV as a guide to divide up the pancreas. And why is it important? It's from surgical planning point of view. So if there is any tumor which is present on the right side of the SMV, which is in this portion here, the disease is essentially going to be treated with um, Whipple surgery. So if there is any disease on this side, it will be treated with Whipple surgery. However, any disease on the left side of the SMV will be treated with distal pancreectomy. It can also be combined with splenectomy if the tumor is present close to the tail of the pancreas. That's why it is important to divide these tumors into two different portions, because surgical planning is going to be different um, for these different diseases or different location of tumors. Once you do this, the next step for you is going to be your assessment of resectability. Now, what are the challenges when you start doing these resectability assessment? Challenge number one, there could be variability in experience. Not everyone will be able to get a really good sense of these diseases when they're doing their residency or fellowships. That is where sessions like these or going for fellowships at cancer institutes is going to help you a lot. Number two, missing pertinent imaging findings. This is a really important thing. It can happen to any one of us. Make sure that you have certain search patterns or develop key areas or blind spots to go after those spots to make sure that you don't miss those pertinent imaging findings, which are going to alter patient management. For example, haziness around celiac axis in a patient who has not received any neoadjuvant treatment may actually be disease present in this region, and it would be under the spectrum of lymphovascular invasion, which will render the patient as surgically unfit. But if you ignore that, then it is going to put the patient at risk of undergoing a surgery, which may not benefit the patient in the long term. Lack of use of reporting templates. So this is a debatable topic here, but I just added it just because it's something which this article also discusses. But lack of reporting templates can put you in danger of not looking at certain areas. So you can develop your own search strategy or develop certain templates. Even if you go to Rad reports, you can download some of those templates, but that just helps you to look at those areas again and again before you sign off your reports. Then lack of adherence of using lexicon. One of the lexicon terminology which we're going to discuss today is what is abutment and what is encasement. You will see that they may be used interchangeably once in a while. And then there could be inter-reader difference in disease extent definition. This is something where we still lack a lot of expertise, and there could be a whole lot of variability when it comes to that point. So now let's understand what are these NCC and criteria for pancreatic ductal adenocarcinoma staging. So we are basically zoning in on the area of head of the pancreas. So what is a resectable disease? As we discussed earlier, there is no disease at these vessels, which we discussed. Celiac axis, common hepatic artery, SMA, portal vein and SMV distortion is not present. You can definitely say that this disease is resectable in the absence of other metastatic involvement. Then what is borderline resectable? So if you see disease at your GDA, which is causing encasement from its origin, the hepatic artery may or may not be involved, but the disease does not involve celiac axis. That is important. It should not go to celiac axis. Now, there could also be SMA encasement, which is not greater than 180 degrees. All of these will put this patient into borderline resectable. As well as in terms of venous structures, you will have SMV or portal vein involvement. And there could be luminal narrowing or distortion. There could be occlusion without suitable anastomotic anatomy. So, I mean, there is a lot of technical jargon here. Don't spend a lot of time to memorize all of these. We are going to look at some examples later. But the important point to remember is that what is this category of borderline resectable? This category of patients are eligible to undergo a round of neoadjuvant chemotherapy. Then they are reassessed with CT again, and we decide if they become resectable now after the treatment. So if the tumor shrinks and these vascular structures are now no longer involved, you can potentially downgrade this patient to resectable. And sometimes it can also upgrade to unresectable if the disease is not responding to chemotherapy. Unresectable, we already looked at one of those examples, disease at the aorta. it is always going to be unresectable if there is any disease present at the aorta. It is called as locally advanced cancer. If you have the disease in the head, and if it causes more than 180 encasement of the SMA, and any celiac axis abutment. So if there is any tissue around celiac axis, it is going to be unresectable. If the tumor is more in the body and tail, so on the left side of the SMV, and if it causes SMA encasement of more than 180 or celiac axis encasement more than 180, it is going to be unresectable. Remember, disease at the IVC, any unreconstructible disease at the superior mesenteric vein and portal vein is going to deem this patient as unresectable. Now, this portion here, it can be discussed with your surgeons to decide if certain venous anatomy can be reconstructed or not. We even have an example of that later on. Lexicon. The most important point to remember, what is meant by abutment and what is meant by encasement. So if you look at these three images from this article, it is a nice graphic representation. So A is nothing but your artery and T is your tumor. So if you divide this vessel with just imaginary line and divide it into two halves, if the tumor is in contact with less than half of this lumen wall, then it is nothing but abutment. But if it becomes more than that, it becomes encasement. And then the tumor could virtually destroy or start destroying walls of this vessel and cause this luminal irregularity, which is pathognomonic of vascular invasion. Whereas this encasement and abutment are just criteria to predict what is the likelihood of vascular invasion. The tumor may be in contact with the vessel, but not involving the vascular adventitia at all. And the tumor may be encasing the vessel, again, without invading the tumor vascular adventitia at all. It just predicts the likelihood of involvement. So the likelihood is greater with encasement and lesser with abutment. That's why there are two different criteria in terms of resectability assessment. But the moment you see this, it is involved. Now, the same holds true for venous tumor contact. So remember, when you're assessing your SMV or main portal vein, you're going to look at this. So the same criteria apply here. You will see your abutment less than 180 degrees and encasement more than 180 degrees. Again, you will have the same thing. So remember, veins are a little bit more pliable than the arteries. So the tumor, which is especially more tough or fibrous kind of tumor, it is going to indent the vascular lumen. And similar to the arterial involvement, it can definitely cause vascular luminal distortion. Both of these are highly concerning for involvement again. Okay, most important point, how to remember this. So again, remember we have three categories: resectable, borderline resectable, and unresectable or locally advanced. Whenever you reach this level of borderline resectable or unresectable category, the challenge is going to be around the borderline resectable, how to assign the patient into this category or whether to consider this category at all, if you can downgrade them into resectable in some way. So now look at the location in the pancreas: head or body or distal body or tail, arterial or venous involvement. In arterial venous involvement, if the degree of contact of tumor with a vessel is less than or equal to 180 degrees, it is called as abutment. And if it is more, and then it is called as encasement. These criteria are going to help you decide if you can assign certain tumors into this borderline category or unresectable category if there is tumor close to a vessel. Okay, so we want to approach this topic with case-based examples. So let's look at some real world cases, and let's see how we can do this. So this is the first case here. Number one, when you look at any of these patients who come to you with a requisition saying they're obstructive jaundice, we scoped the patient, there was a mass or stricture, we put a stent in there, assess for resectability. That is how most of these patients might present. Some of those who are presenting to emerge will have not seen any person beforehand, and they will just present de novo with upper abdominal symptoms, obstructive jaundice. So you have to make sure that, do you see the mass or not in the head of pancreas? So in this case, you can definitely see that I can delineate that there is this kind of really ill-defined mass which is present within the head of the pancreas. So the answer to this question is yes, you do see a mass in the head of the pancreas. Now, what is going to be the next step? You look at your major vessels. So this is the axial arterial phase or pancreatic parenchymal phase. You definitely see that the mass is not going to the region of the abdominal aorta. Then this is the coronal phase, and you definitely see that this fat plane around the celiac axis and SMA is totally clear. And if you look at this coronal reformat, again, this is nothing but your SMA and SMV region. That's the portal vein, and the bulk of the tumor is present in this area. So essentially, let's answer these questions one by one. Is celiac axis, SMA, or hepatic artery involved? No. Is there disease at portal vein or SMV? No. Is IVC involved? No. Is the aorta involved? No. So answer to all of these questions are no, which means that this is nothing but a resectable disease, and this patient will undergo surgery. But again, remember that it's not always a success story, despite how hard you try. And one of the reasons for that is we discussed earlier that there is a large proportion of cases where there is microscopic perineural and lymphovascular invasion, which you will find at the final pathology specimens, which is not going to be detectable by imaging. And those are the patients who end up getting recurrences or metastases. So this patient, unfortunately, around 6 to 8 months later, had an imaging which showed suspicious lesions. So you can definitely see there is one rim enhancing lesion here, one in the right lobe, and another interval CT was performed as the patient deteriorated. They developed new and enlarging lesions. So it's not always going to be a success story, but you are just trying to make sure that you diligently assess these CTs to increase the survival benefit of these patients. Next patient or next case here. Again, the first question, always start by asking yourself, is there a visible mass? So I'm definitely not sure how you see it on your image, but it's nothing but this area of abnormality. So you see this hypodense mass in the head of the pancreas. That's your primary carcinoma, and you also see the stent which is put into the CBD because the patient presented with obstructive jaundice, and the endoscopist inserted a stent there, did some brushings. So they already have a diagnosis of malignant pathology. So let's see if we can locally stage this disease. So again, we start with our assessment tools. So we have your axial arterial phase, coronal arterial phase MIP image, and then your coronal portal venous phase image. So let's start asking ourselves these questions. Is the celiac axis, SMA, or hepatic artery involved? So you can actually see that there is disease here present at the hepatic artery, but the celiac axis is kind of here in this case. And then the second thing which is happening here is that the splenomesenteric confluence, if you see here, that is distorted. What else is happening here? This was one of the cases which I added to the quiz question. So this was the coronal MIP, which I was talking to you about. So you definitely see that that's the common hepatic and that's the GDA. So even the GDA is occluded by the tumor. So there are certain red flags going on here. Number one is there's disease which is present at the hepatic artery, but not going to the celiac axis. Then there's disease which is occluding the GDA, and there's some distortion at the mesenteric and splenic confluence. So this patient ended up going to tumor boards, and on tumor boards, it was decided that they could potentially reconstruct this portion of the disease once the patient undergoes neoadjuvant treatment and these areas improve. It is really important to discuss this with your surgeons. Now, how can you be of added value when you're dealing with these patients? Look for variant anatomies because that can change a whole lot of things. So what are the most common vascular or variant anatomies which can help you in this situation is an aberrant or replaced right hepatic artery. So what happens in that case is that the right hepatic artery arises from somewhere over here on the SMA and goes behind the pancreas and into the liver. So in that case, what happens is that even if the hepatic artery is in close contact with this tumor here, there will be a replaced right hepatic artery which is coming from somewhere over here, which has no disease at all. That totally changes the level of confidence of the surgeons when they are going to perform surgeries in this patient, because now the vascular supply to the liver is not going to be compromised because of this replaced right hepatic artery. So always look for those vascular variants. Now let's look at another case example here. So before we start discussing this case, I would highly recommend that if you have any questions as we go through these cases, remember now we are at case number 3. So if you have any questions about these cases, use YouTube live chat section and you can just write case 3, I don't understand this, or case 4, why was certain imaging test not done? So you can just type those answers in the question box. We can review those later once we go through all these cases. So this is another case here, case number 3. So I know that it's a little bit hard on your screen to look at the tumor, but again, start by asking yourself this question, is there a visible mass, yes or no? So I just provided this MRCP image because this patient unfortunately went that route. They had an ultrasound which showed biliary dilatation, and they decided that the patient has to undergo an MRCP to assess that. So we did the MRCP, and then again, we were kind of left with a mass in the head of the pancreas. So in this case, this is the area where the mass is present in the head of the pancreas. Again, it's going to be very hard on most of the occasions, but remember to have your pancreatic parenchymal phase. So in this case, it was a little bit too early, and that makes it some challenging. That makes it challenging to assess this lesion. So remember to use your phases. But this was the area of the tumor. So once we do that, we'll again go by our algorithm. So is there any tumor at these major vessels, celiac axis, SMA, or hepatic artery? Look at this thing, everything is clear. And then I know that this is not one of the nicest images, but I'll just outline the portal vein and the confluence here for you. So the tumor is definitely away from that area. And then there is nothing around the aorta, as well as the IVC. We saw that subsequently, even on the MR, there was nice fat plane between the posterior part of the head of the pancreas and the IVC. So this tumor was deemed as resectable, but this case has one is really important finding, which we talked about in the last case. What about these vascular variants? So let's see what vascular variants we do have here. So the first branch, which is coming from the ventral abdominal aorta, which is the first major branch of our interest, is nothing but your left gastric and splenic artery, which are arising directly from the aorta. Then the next branch you see here, this is nothing but the common hepatic artery, which is arising directly from the aorta. So this common hepatic artery is giving the right and left hepatic arteries as well as the GDA. And then as you go down, what is happening in this case is that that's the SMA, which has a separate origin. This common hepatic artery can be called as a common hepatic artery by definition if it gives any one of the hepatic arterial branches and gives off the gastroduodenal artery. So it can be giving rise to only the left hepatic artery and GDA, and it can still be called as a common hepatic artery by definition. And in this case, like suspected, there is actually replaced right hepatic artery. So if you see these tiny vascular channels which are coming here, one which is highlighted here, that is nothing but the replaced right hepatic artery, which is arising from the SMA. So there are so many vascular variants happening in this case. Fortunately, there was no tumor at many of the major vessels, but if there was, for example, tumor close to the left hepatic artery, you definitely won't compromise the patient's blood supply to the liver because there is a replaced right hepatic artery in this case. So always remember that you look at these variants. So what are the variants which are definitely worth reporting? Number one, accessory right hepatic artery, replaced right hepatic artery, as we looked at in this case, or replaced common hepatic artery. All of these variants are nothing but vascular channels which are not arising from their common anatomical origin, namely celiac axis. They could be arising from the aorta, arising from the SMA. It is very important for you to describe their origin. And if there is tumor in contact with this vessel, you have to apply the same principles, whether there is abutment or encasement of the tumor, or whether there is obvious luminal irregularity, which is nothing but invasion. Okay, next case here, number 4, is there a visible mass in this pancreas? So obviously you can see the visible mass, and then you see that there is a stent here in the CVT. What else is happening here? There are a bunch of things, but for those of you who already noticed, keep that in your mind so that you can start applying that in your algorithm. So let's look at this axial arterial or pancreatic parenchymal phase. You do see that the celiac axis and the hepatic artery are nice and clear here. And then you do see that there are a bunch of other things happening here, which is nothing but you have to pay attention to your SMV. But there is no disease here along the celiac axis and SMA. But in this one coronal slice, you can definitely see that there is tumor which is in contact with the right lateral border of the SMV. So there is less than 180-degree tumor contact with the SMV. So the SMV is kind of, there is abutment of the SMV as we discussed by definition. So this case is nothing but resectable. If there was encasement here, that would have changed the category, but this was abutment. To see how use of lexicon is so important when deciding whether a tumor is resectable or borderline resectable. You have to really understand the differences between these two terminologies and remember that they are not the same. Abutment and encasement are both completely different entities. Case number 5. So is there a visible mass? So answer is obviously yes. You definitely see all of this hypodense spiculated mass Pay attention to what is happening to the vessels here, which is going to help you decide what to do with this patient. Let's look at this axial image, arterial phase, no tumor along the celiac axis or the common hepatic artery and the splenic artery. But on this coronal arterial phase of image, you can definitely see that there is encasement of the SMA. See, the SMA is completely gone. And then there is abutment of one of the hepatic arteries. It's not really nicely appreciated on this axial view, but if you look at that on coronal, you can definitely appreciate that there is abutment of the hepatic artery at this level. So there are two red flags now: complete encasement of the superior mesenteric artery, and then there's abutment of the hepatic artery. What else is happening here? I'm not 100% sure how you see it on your image, but if you look at this coronal portal venous phase image, look at how many collaterals have developed here, which itself means that the your what I can say, the portal vein is going to be obstructed in this case. It's completely occluded, which is nothing but your portal venous distortion or involvement. So more than 180-degree circumference of the vessel, so nothing but encasement. And then portal vein is involved in this case. And then if you pay close attention to this image here, this will just show you that that's the site where the portal vein should have been present, but it's again kind of completely occluded. And what else is happening here? There is disease at the aorta. So remember, we talked about this, that any disease which reaches the abdominal aorta, it's going to be unresectable. So there are multiple factors in this patient which deem this patient as unresectable for surgery. So let's look at another case here. Case number 6. Is there a visible mass? So this is one of those cases where it is so obvious that you can definitely find out that there is a cancer. And that is because of this necrotic portion of the tumor. But remember, all of these things surrounding it is also probably going to be disease. And it always helps you to look at the pancreatic parenchymal phase to decide how it looks different from the pancreas. So the answer is yes. Again, we do our usual stuff. Let's go to the celiac axis. Let's look at the common hepatic artery and then your splenic artery there. So there is no disease here. And again, the same thing here. The only thing changes on this coronal image is that I'm not sure how you appreciate it, but pay attention to this haziness around the celiac axis. If you do appreciate that, please put this in your mind, that haziness around these major vessels could also be disease. And that's one of the drawbacks of imaging, that we still are not able to distinguish it sometimes. What is disease, what is treatment response, what is just inflammation after pancreatitis. And unfortunately, that is something which you have to decide based on multiple other factors going on in this patient. If you look at this sagittal portal venous phase image, please apologize for a wrong annotation there. But if you look at this sagittal portal venous phase image, that's the SMV. And this is where the confluence as well as the main portal vein should have been present. So the confluence is totally involved by the disease, and even the portal venous phase. Portal vein is also involved in that phase. So we have two things going on. You see some haziness around the celiac axis. You do see that there is SMV and portal vein involvement. What else is happening here is that, sorry, I'll just get rid of that. Okay, so what else is happening here is that, if you remember, for SMV and SMA, they are essentially be responsible for the vasculature and vascular supply, as well as sustenance of predominantly small bowel, as well as some portions of the large bowel. So as liver is important, even the mesenteric supply to these important small bowels is also important. So if there is any tumor which is present in the SMA or SMV, now we have to start looking at what is happening to their branches. Most commonly, the first branch of the SMA or the first tributaries of the SMV. So in this case, you do see that these tributaries are also involved by the tumor. So if you see this collateral or dilated channel on the right side of the tumor, it is completely getting obstructed. This is nothing but the first tributary, which is joining the SMV. As the tumor is present at that confluence, even this is gone. And the same thing is happening here on the left side. One of the tributaries which is coming in is completely obstructed. So why is this important? Say if there was no disease at the celiac axis or no disease at the superior mesenteric artery, and maybe the portal vein was present, but this area was involved, the surgeons are not going to like this, because how are they going to revascularize the bowel there is no way in which they can create anastomotic channels to revascular bowel in this particular case. So again, this is an important discussion which you need to have with your surgeon to decide whether they want to proceed with surgery, especially in situations where disease is extending along the mesenteric vessels. So this disease was unresectable for multiple reasons, but really important to look at this portion of the disease as well. So teaching point in this case is that always make sure that you look at SMV and SMA. Look at the first branches. Jejunal or colic branches can alter surgical management, and the same applies for venous involvement, which we saw in this case. Don't forget to check your veins. Make sure that it is one of your search protocols. Let's look at the next case. Case number 7. Is there a visible mass? So if you remember, this was one of the patients which I showed in one of the images before. This is a coronal portal venous phase. You do see dilated ducts with abrupt cutoff. Again, the differentials here are going to be distal CBD cholangio, an ampullary carcinoma, or a pancreatic cancer, which is so isodense to the head of the pancreas that you don't find it. Unfortunately for this patient, they waited probably a little bit too long to get an MR done, but let's look at what MR looks like. Because it is important to understand how it looks like on MR as well. You should not be just focusing on CT. So you may get a patient once in a while for an MR requisition for these diseases. My go-to sequence is the pre-contrast T1. So we acquire wide T1, which is, you may have a similar comparison at your institute. The normal pancreas is going to appear bright like this. So see, look at the body and tail of the pancreas, but the tumor is going to appear like this. So it helps so much to narrow down your area of search. Once you do that, you go to your dynamic phases of post-contrast acquisition, and that may help you identify the area of tumor, which in this case is this area. There was a little bit of heterogeneous enhancement, and that was less than the normal parenchyma. So this cancer was called as resectable. With the help of this case, let's discuss about something really important. CT and MR have been compared in the past to see which one is performing better. Some of the studies or some of the systematic reviews have demonstrated that there's no significant difference in terms of local staging when it comes to CTs or pancreas or the MR examinations. However, anecdotally, there is increased evidence in literature which says that MR detects more number of liver mets. And even a single metastatic site renders this patient inoperable, as this is considered as already advanced disease. So it's important to understand how the appearance looks like on MR as well. So then let's look at another, I mean, we are kind of wrapping out just last few things to talk about. Case number 8, it will not always be head of the pancreas. Especially if the disease is occurring in the body or tail of the pancreas, they usually present in pretty advanced stage because there are not enough obstructive symptoms which will make the patient come to you early. So remember, if the disease is present in the head, it is going to cause obstructive jaundice for most of the times, or maybe intestinal obstruction if the mass is periampullary. But if it's in the distal body or tail of the pancreas, all you may have is vague abdominal pain. There could be multiple attempts at scanning with ultrasound with no results and all those kinds of things. And once they appear, once they present for CT, it's already too late. For example, this locally advanced cancer in the distal body of the pancreas, you see that the disease is involving the stomach here. And then there is a lot of lymphovascular invasion in the form of disease along celiac axis. So do you appreciate that on this sagittal view? Look at how there is soft tissue extending all the way from this tumor along the celiac axis. So it's already inoperable at this stage. Other example, cancer in the tail of the pancreas. So again, this is something which may present if the patient develops focal pancreatitis because of obstructive symptoms. So whenever you're reading MRCP exams or even CT, if you just see focal dilatation anywhere in the distal body or tail of the pancreas, always look for a cause of it. It is not normal to have focal dilatation of the pancreas. So in this case, this was the region of transition. That was a dilated duct. Again, on MR, you see that, look at your T1 image, see how bright the pancreas looks like. This is the site of the tumor, and this shows a focus of diffusion restriction. This patient underwent distal pancreectomy and splenectomy and had the final diagnosis of adenocarcinoma of the pancreas. It was moderately differentiated. So now, before we close today's discussion, some things worth remembering. Always watch out. Over 90% of these tumors are going to be pancreatic ductal adenocarcinomas. But with any other imaging pathology, the diseases don't read our books. So they will like to present as something else. What are other subtypes of adenocarcinomas? You can have colloid, adenosquamous, mucinous forms. Approximately 10% of adenocarcinomas are hypoattenuating. So remember, you may not see them that well. And then in these cases, you have to focus on secondary signs like dilated ducts, abrupt cutoff, or change in the contour, all those kinds of things. Secondary signs worth noting are duct dilatation, infiltration, or peritoneal cysts, which can help you find the site of the disease. Also remember, another great mimicker is mass-forming pancreatitis. The only way to differentiate those is that you will see this called as traversing duct sign. Look at this borrowed coronal MRCP image. You can definitely see that the duct is traversing through that area, which was thought to represent a mass, which will potentially rule out an adenocarcinoma. Nonetheless, a biopsy may still be warranted under endoscopy guidance. How to differentiate these two entities, because this is something which they will ask you in your boards, that they will give you a case, periampullary mass, and why it is not mass-forming pancreatitis, and why are you zoning in only on pancreatic adenocarcinomas. So we talked about duct penetrating sign, which is present in mass-forming pancreatitis, or may be present depending on how much is the degree of inflammation, but it is typically absent in the cancers. Then collateral duct dilatations, duct to parenchyma ratio, displaced calcifications, double duct sign, all of these are going to be different signs which will definitely help you to be in favor of one versus the other. To know more about this article, you can go to this article on chronic pancreatic tumors. It's nothing but a very nice infographic from 2019 in Radiographics by Wolski et al. So it's a really nice article which discusses about how to differentiate these two. So what are going to be your typical features which are going to be absent in mass-forming pancreatitis? The double duct sign is going to be typically absent. Displaced calcifications are going to be typically absent there. The calcifications will be present inside of that mass-forming pancreatitis. And then whatever is not there on this side will be a red flag to point towards pancreatic ductal adenocarcinoma. So that's all for today. Those were just some interesting cases. For anybody who has questions, feel free to use our YouTube chat, live chat features. I'll be happy to answer them. If you want me to go through any slide again, any case again, I can go back to that case and we can discuss that again.
That was Dr. Amar Udare. He's a staff radiologist at Hamilton Health Sciences. Not only he's a fantastic radiologist and radiology educator, he's also a bird photographer and an amateur musician. Amar, we have a question from the audience. Brucey B asks, what landmarks do you use for deciding? I think you covered at the start of the talk. If you can go over that again, that'll be great.
Right. So thanks for that question, Brucey. So as we already discussed about this, always look at your SMV. SMV is going to be your friend to decide whether the mass is present in the uncinate process, head, body, or tail. Most of the masses in the uncinate and all the masses in the head will be present to the right side of this SMV, which will essentially mean that they will be amenable for Whipple surgery. And all the masses which are present to the left side of this SMV will be in the body and tail of the pancreas, and which won't be amenable for Whipple. And they may have to undergo distal pancreectomy with splenectomy, as we saw in one of the cases. So I hope that helps.
Thanks, Amar, for that wonderful session. And I think this will make this difficult concept of pancreatic adenocarcinoma relatively simple for all our viewers. If you're new here, make sure you subscribe to the channel so that you get access to all the videos that we do. Remember, we do these sessions every Saturday at 8 p.m. India time and 9:30 or 10:30 Eastern time, depending on daylight savings. If you like this video, do let us know in the comment section or give it a thumbs up. If you have any more questions, you can let us know in the comments and we'll try to answer them. Finally, if you registered for this using our event platform, you'll get a feedback email and you can let us know how we can do things better here. With that, I'd like to end today's sessions. Thank you, Amar, once again. And thank you, everyone, for attending this session on a weekend, and hope you have a fun weekend. Bye-bye.
Thanks, everyone. Have a good day.